Good evening, welcome. It's nice to see so many people joining us today. So this is for our open session for vets on POCUS, the revolutionary bedside ultrasound. So thank you everyone for joining. So before we start, I just want to let everyone know that the session is being recorded. Please also keep an eye on the chat box, and we'll share a link for you to register your attendance so you can receive your certificate of attendance at the end of the session. So just keep your eye on the chat box. There will also be a QR code as well, so we will make sure that you've all got your attendance certificates at the end. So my name is Selina Hornbuckle. I'm one of the programme tutors for the distance learning programmes that improve. With me tonight I have Alison Babington, who is a business development and digital learning coordinator, and I have Fran Blake, digital learning coordinator, and Ludivine Boiron, who's a specialist in ECC. This evening, we're going to start with an overview of the Emergency Medicine and Surgery Distance Learning Programme. That will include a quick demonstration of one of the interactive lessons. But I just want to let you know that Ludivine has been experiencing some internet connection difficulties. So what we're going to do is we'll begin by introducing the programme, and then hopefully we can hand over to her afterwards for her presentation. So we'll turn our attention then to the exciting topic of emergency and critical care. Ludivine Boiron is one of the authors of the Emergency Medicine and Surgery course, and she is joining us and will share her knowledge on the point of care ultrasound. We'll be taking questions via the chat box. So at the end of the session, there will be an opportunity for you to ask us questions about the programme and also to ask Ludivine about her presentation. So you can use the menu shown along the bottom. You can send your questions to us there. You can click on the chat box or you can raise your hand and the Q&A. And then we'll add a link, as I mentioned earlier, we'll add a link to the chat box for you to follow so you can receive your CPD certificate after the session. So to start, Alison's going to give you a brief overview of Improve. Thanks, Alison. You're on mute.
Well done, Selina. Good evening, everyone. Thank you very much. Some of you will be familiar with Improve, but for those of you who are not, we thought it'd be helpful to give you a brief introduction. Improve's been providing veterinary CPD to veterinary professionals globally for over 20 years and was the originator of modular CPD. We are continually adapting and innovating our teaching and learning, from face-to-face lectures and practical training to the more recent distance learning programs. We are a truly global company, offering CPD in countries as varied as Japan, China, Australia, and many European countries. In 2020, we delivered over 400 different CPD courses, providing over 1,000 days of training to the profession. Improve was created by a group of vets passionate about delivering high-quality continuous education to the profession, and this is still the case today. By studying with us, you will take back to practice new skills, knowledge, enthusiasm, and confidence to handle those challenging clinical cases. Could you move the slide? Thank you. Our programmes are accredited by ISVPS and validated by Harper Adams University. Throughout the programme, you can start work towards a GP Cert qualification awarded by ISVPS. ISVPS have already globally awarded more than 5,000 vets with a GP Cert title. By enrolling then with Harper Adams University and undertaking further study with them, you can also gain a postgraduate certificate, which is recognised by the RCVS as an eligible entry qualification for advanced practitioner status. During our presentation today, we will be showcasing our online emergency medicine and surgery programme. However, this is also available as a face-to-face attended programme starting in January 2022 and will be delivered in our venue in Swindon, Wiltshire. Throughout 2022, we'll be delivering a wide range of face-to-face modular programmes and also short courses for both vets and nurses in a COVID-secure environment. Please have a look at our website for further details. Thank you for listening, and I'm now going to pass to Fran Blake, who is going to give you a brief overview of the platform of the programme, followed by a short demonstration on our learning management platform. Thank you for listening.
Thank you, Alison. Hi, everyone. My name's Fran, and I'm one of the digital learning coordinators at Improve and a vet myself. So I'm going to give you a brief introduction as to how our distance learning programs work and what the course and the lessons actually look like, so that you know what to expect. Our world-leading distance learning programs have evolved over the years, and they were developed to create a very new online learning experience. So the content's been developed, but it's also been reviewed by veterinary specialists, and it's hosted on an innovative platform. You're supported on the program by module tutors who are specialists in their field. So they not only author the content, but they also provide ongoing support through an online forum as you progress through the course. The lessons are presented in an engaging and intuitive style with various learning activities to keep your interest and to help you learn. So these include the use of interactive quizzes, videos, labeling images, drag and drop exercises and MCQs. We really wanted to make this an active learning experience that was as engaging as possible. One of the main benefits of the course being online is that you can access your learning anytime you want and fit in your studies around busy practice commitments and life in general, just so that it's easier to achieve that work-life balance. So moving on more specifically to the emergency course, it will be starting on the 1st of November 2021 and will be running until the 31st of March 2023. Our course director is Ludivine, who we will be hopefully having later on this evening to give our CPD talk on point of care ultrasound. She oversees the whole programme and ensures that all of the content is relevant and up to date, and will also be teaching one of the modules later next year, as well as some of the practical days. There are 2 breaks every year in August and December, and during these months there aren't any new lessons released, so these breaks can be used to catch up or review previous month's content, or to consolidate your learning, or just take a well-earned break. There are 14 interactive modules covering subjects ranging from the initial stabilization of your emergency patient to more specific management of toxicology, neurological or cardiovascular emergencies. It really is a really comprehensive ECC course, and you can find a more detailed breakdown of each of our modules on our website. There's also the option of signing up for 3 additional practical days at the end of the course in 2023. So in total, these lessons have been written by 15 veterinary specialists who've contributed to the programme and brought with them a huge array of experience and knowledge. So moving on to what each of these modules includes. As I mentioned, there are 14 modules. Each one is released once per month, and they all follow a similar structure. So we have a pre and post module assessment so that you can evaluate your progress. There are 9 interactive lessons per module, so they're released 3 in the first 3 weeks. The 4th week is slightly different in that we have 2 case studies where you can apply your knowledge to real life cases. And then accompanying all of that, we have a set of written notes that accompany the lessons, as well as recommended reading lists and an introduction and weekly summary videos from that month's speaker. So all of that is then supported by a discussion forum where you can share your cases with your peers and your module tutor. You can ask questions about those cases or anything that you've learned throughout the lessons. Moving on to our learning platform itself, Moodle, it provides a really unique environment where you can learn. I actually completed the face-to-face certificate with Improve a couple of years ago, and I have to say that the distance learning course is incredibly thorough and engaging, with a variety of resources that make it really comparable to in-person teaching, but it does have the added advantage of being more flexible in terms of when and where you study, and whether you like to set aside large chunks of time for that, or whether you want to do it in smaller bits and pieces around your other commitments. It all follows a similar format. So here we can see the Moodle appearance for each module. So at the beginning, you have a module introduction with some learning objectives and a video from your tutor that month. Then each week you will have 3 lessons released per week to work through. As I mentioned before, in the 4th week, it's slightly different in that you'll get these 2 case studies that are interactive and kind of consolidate everything you've learned in the previous lessons. The discussion is where you'll access the forum that I mentioned earlier so that you can interact with your peers and your module tutor. And then you have your recommended reading and a course evaluation, which is basically a feedback questionnaire for that module. So now if I take you to demonstrate a specific lesson so that you can see what they look like. Okay, so here I've opened up a lesson on the approach to respiratory emergencies. This is actually taken from our small animal medicine course, which is currently running. So when we enter the course, you can see on the side, we have a contents bar, which summarizes all of the sections from the lessons, from the introduction at the beginning and the learning objectives, all the way down through all of the topics to your end of lesson quiz. Each lesson has one of these end of lesson quizzes. They work as a form of self-assessment, self-evaluation, and really summarize everything that you've learned in that lesson. If we scroll back up to the top, you can see that we have a progress bar up here. So this shows you how far through the lesson you are. And if you want to leave the lesson and come back to it at a later date, it will save your progress so you know where to pick back up from, which is really great if you want to do these lessons in smaller chunks so that you can fit it into breaks at work or while you're waiting for dinner to cook, for example. You don't have to commit to doing a whole lesson in one go. And so I'm not going to go through the whole lesson, but I just want to give you a bit of an idea as to how we make these a little bit more interactive and some of the kind of activities that you may come across. So it's quite an intuitive program. To progress through, you simply scroll down and then click to continue on to the next section. Here we can see an example of one of these are called our drag and drop exercises. So you simply have to drag the word into its correct position. And as you do so, it will let you know whether you're right or wrong. If we move down to a later section here on oxygen supplementation, we can see that some parts of the lesson are a little bit more traditional in their teaching. So we have text and images to accompany it. But throughout this, we've peppered the lesson with a variety of activities to keep you engaged and also keep consolidating that knowledge. So for example, here we have a sorting activity on the advantages and disadvantages of oxygen tents. And all you have to do is simply drag it into whether it is an advantage or a disadvantage. And if you get it wrong, it will just bounce back up to the top. If we move on to another section, this just shows us another alternative example of some of the matching exercises that we have. And lastly, this section here nicely demonstrates how easy it is for us to incorporate clinical images, such as radiographs, for example, here. But we can also include videos. So for some aspects, they're much better demonstrated by video. So if we scroll down, we have here a video of a specific breathing pattern in a cat, and then that's followed up by a little activity of asking you to classify which respiratory pattern that is. And as I mentioned before, at the very end of the lesson, you will come to an end of lesson quiz, which is just 3 multiple choice questions, and that summarizes everything you've just been through. Each lesson is roughly aimed to take about 45 minutes of time. But as I mentioned, you can do those in small sections or all in one go. Okay, so that's just a flavor of how the platform performs. If you have got any questions on the course, you can pop them in the chat box and we'll answer them. Or if you've got any questions on the talk, you can do so and we'll pass those over to Ludivine at the end. So I'm just going to stop sharing my screen and we'll see. Over to you, Ludivine. See. I don't know whether Ludivine's with us or whether we're having some technical difficulties.
Shall we take a 5-minute break if people would like to stay connected, and we'll just see if we can contact Ludivine and hopefully perhaps we can get her presentation and she can dial in and talk through it. So if people don't mind just taking a few minutes break, and we will see if we can get everything up and running again in a moment. Thank you.
Have the presentation through now, and I'm just going to introduce you and pass you over to our wonderful Ludivine, who is going to be talking to us this evening about POCUS, the revolutionary bedside ultrasound. Over to you, Ludie.
Thank you very much. Thank you, guys. If you can't hear me very well, just let me know. Otherwise, thank you again for attending this presentation tonight. I'm very, very happy to be with you. And it's an honor for me to be the course director of this amazing program. So for this presentation tonight, I chose a topic. I hope this topic will be interesting for you, because I think as an emergency clinician, the POCUS is quite revolutionary for me. So I hope that through this presentation, you'll be able to learn a few things, and don't hesitate at the end if you have any question. So we can start now with this presentation. Next. Okay, so just for the presentation of this talk, so we will go through a few definitions, because the POCUS has evaluated a lot for the last years. So just doing some definitions, some progression of this POCUS through the few last years. We will see where we can apply the POCUS, and we will go through the different techniques. The two main parts of this presentation will be the first part, the thoracic ultrasound, and the abdominal ultrasound. Next. Okay, so just a few bit of history. So the point of care ultrasound, as we name POCUS, we can also call it bedside ultrasound or focus ultrasound. And it's coming from many other things from the human medicine. And for the last 15 years, about 15 years, it has been a lot of growth for this technique, and a lot of new protocol standardization of this technique has been explored. So as you probably know, TFAS and AFAS, they are the most commonly terms that we use, but these terms have been patented in the United States. So now we should not use it anymore, and this is the reason why we use more and more the term POCUS for point of care ultrasound. Important to remember that POCUS is not an ultrasound for the radiologist or an imaging specialist, but it's for everyone, from the generalist practitioner and also the specialist. So initially, the FAST was done and defined for the trauma patients, but as you will see in this talk, it has been extended to many, many other conditions: respiratory, heart disease, fluid overload, detection of mass, and everything else. So the first term of flash ultrasound has been determined in 2004, and then Lisandro in 2008 did define the TFAS protocol and the AFAS protocol, also defining the abdominal fluid score, the AFS. In 2014, because we knew that we could do much more with this quick ultrasound, there was a new protocol called VET-Blue that has been established. And the VET-Blue plus the TFAS and AFAS are called now the Global FAST. So the Global FAST, as you can see, takes advantage to everything, the TFAS, the AFAS, and the vet blue. So we can see and look for some effusion. We can look for some major heart problem. We can see the lungs. So really, really a lot of information that we can get from this global FAST. Next. So this slide is very, very easily written, but I just wanted to mention that there is so many things, again, that we can see, so many information we can grab in emergency by doing a POCUS. So we can see, we can gain a lot of information via the traumatic patient, looking for effusion, pneumothorax, diaphragmatic hernia, to assess the volemia of the patient. Cardiac abnormalities, again, many things that we can earn from the TFAS to see if we have maybe a wet lung with some B lines present. We can assess the function of the heart with the systolic function. I mean, there is a big list, as you can see here, of information that we can get when we are used to practice the TFAS or the POCUS, the thoracic POCUS. So really, I want you to be aware, if you are not used to do the TFAS, that again, being comfortable by doing this technique can give you a lot of information. Other things, so respiratory abnormalities, we can see or we can at least suspect if you have a traumatic patient, for example, a pneumothorax. We can see pleural effusion. This is probably the most easiest things to see. We can also visualize some mass in the abdomen or in the chest. CPR, we can use POCUS when we perform a CPR because we know that the pulse palpation, for example, is not a sensitive tool during the CPR. So having a machine ready and looking at the heart when you change the compressor can be also a very good technique to see if there is a heartbeat or not. And there's many other applications, as you can again see on this slide. Next. So to be able to do a POCUS, you need to be trained and you need to be comfortable with the technique. So again, you need to know your ultrasound machine, very basic, but it's very important. And you need to be able to practice the POCUS independently of the patient compliance and disease. So it's important to know the normal lungs first to be able to detect the abnormalities. So I really encourage you, if you have a normal healthy patient in your practice, to try to train yourself on this patient to be able to see the normal picture of the lungs or the normal picture of the abdomen, and then switch to the sick patient. So again, doing a POCUS, so it's a fast ultrasound. And if you take the signalement of the patient, the history of the patient, you can, again, have a lot of information and maybe get a diagnosis just with this. Next. So the general technique, very simple. You don't need to clip. You should not clip when you do a POCUS. At the beginning, you can if you want to be more comfortable, but at the end and quickly, you should not clip anymore. You can use alcohol plus or minus gel. I personally use gel because I feel like it makes the contact with the probe much easier. Be careful to not drown your patient with alcohol because they are usually very sick and they can be very cold just because of the alcohol. You can do it in sternal or lateral decubitus, lateral position, standing position. It depends on the patient, depends on his disease. It depends on how stable it is. So just do the best for the patient and for you. Generally, we use the B mode, and occasionally you can use the M mode and the color Doppler if you are very comfortable, especially when you assess the heart. But really, one of the messages I want you to remember from this presentation is that the POCUS, personally, I love the POCUS because it's amazing. It's an amazing tool, but the POCUS will never replace a physical exam. So you can't skip the physical exam and jump on your POCUS. And the POCUS will never give you a diagnosis of certitude. Usually, and most of the times, you will have to correlate with the physical exam and other diagnostics that can be mandatory. So doing a pro-BNP, an X-rays when they are more stable, an echocardiography, and the fluid analysis, etc. If we look at the TFAS and the radiograph, so again, there is a kind of a battle between these two things. So you can see, and again, it will depend on your patient, but the TFAS, the best advantages of the TFAS would be that it's very quick. You should be a TFAS and an AFAS in less than 10 minutes, definitely, less than 5 to 7 minutes if it's possible. When you are used to do this, it's definitely possible. There is no irradiation. It's definitely affordable. You don't need a sedation because it's a bedside. It's a bedside technique, and if you have a critical patient, you should be able to do it without sedation. You don't request a lot of practice. A little bit, yes, for sure, but the learning curve is very, very quick. You can do FNAs of some organs, a bladder, for example, thanks to the FAS or the TFAS, depending on what you want to FNA. And again, during the CPR, it can be also very helpful. So it's not a cheap ultrasound. You don't have to consider it's a cheap ultrasound because it's a real and important diagnostic. And it's very important to give the importance of this POCUS. So the part one will be the thoracic POCUS, because I think it's probably the most difficult part of the POCUS to do, the thoracic one, and many changes, many progress have been done in the different protocols. So we're going to go through each of them now. So everything did start in 2008, as I said previously, by Lisandro, which is the mentor, the boss of the POCUS. So he did define the TFAS as a thoracic focus assessment with sonography for trauma. So initially for trauma, it was initially done to rule out or rule in the presence of fluid or air in the pleural space and the presence of fluid in the pericardial cavity. So I'm sure that most of you know what is a TFAS and potentially how to do a TFAS. It's quite simple. So it's important to know that if you are looking for fluid, you will have to look at more ventral view. And if you are looking for air, you will need to look more in the dorsal view. There are 5 sites to check: the chest tube site bilaterally, the pericardic site, also on the right and the left, and the diaphragmatico-hepatico sites, as you can see on this slide. So again, important to know what is the normal picture that you have to see. Observe in these 2 picture. So you should see the ribs, which will be the black vertical line. So they look like a shadow lines. The pleural lines will be the line that is the most hyperechoic here. I don't know if you can see my arrow. Can we see my arrow? No, maybe not. So if you don't see my arrow, you can see that the pleural space, the pleural line is shown by the long white arrow. So with the black arrow, it's also the pleural line, and the white and black arrow, you can see that it's formed a bat signs or the alligator signs. So this is a funny name just to illustrate the normal picture that you can see with the rib shallowing and the pleural line. The short white arrow means the A lines, which are normal. They are parallel to the pleural line, and this is a normal image. So the A lines, again, it's a normal image that you should see in a healthy lung of your patient. So they are horizontal to the screen, they are parallel to the pleural line, again, they are parallel to each other and quite equidistant. And they represent just the reverberation artifacts of a normal aerated lung when in the presence of a sliding lung. So again, A lines means normal. So now we're going to see what you can see as a pathology when you do a TFAS. So we can see first, we can look for some fluids. So fluids in the pleural space and fluid in the pericardial space. So let's start with the pleural effusion now. So this is a dog that came in, if we can run the video. So there is maybe the slide before, if we can go back. Yeah, perfect. So if it works. Let's see. So I know that we may need to have quick time, or do you think, Fran?
Fran, is it working on your computer screen?
It was when I first downloaded it, but now it isn't running.
Do you think maybe if you close down the presentation and reopen it?
Yeah, I can give that a go.
Okay, so let's see if it works.
No. Some of them definitely did play because I had a quick flick through and they were playing. So I don't know.
We can move to the next one. I mean, it was just an example of a pleural effusion, but I'm sure, guys, that every of you already scanned a dog with a pleural effusion. So we can move to the other one. So this is a pericardial effusion. So let's see if it works. If it doesn't work, you can see very well in this picture anyway that to do the distinction between a pleural and a pericardial effusion can be a little bit tricky sometimes. But on this picture, for example, you can see that pericardial effusion is a very, very round effusion. So it's in the bag, in the pericardial bag. So there is definitely a membrane that contains the fluids. So you can see the difference usually between a pleural effusion and a pericardial effusion. So this one was a pericardial effusion due to a cardiac tamponade. So as you can see, so this one is working, so that's good. So what is very important again is to know what is normal. So in the normal lungs, you should see what we call a glide sign. So I don't know if every of you know what is a glide sign, but it's a dynamic process. And it's normal. Why? Because in the normal physiology, between the visceral and the parietal pleura, there is a very, very tiny layer of fluid. This is physiologic. And the respiration creates a movement as one pleura glides over the other one. So this is what we call a glide sign. And this, seeing a glide sign is going to be very, very important because it can, for example, helps you to rule out a pneumothorax. So for example, if you see a glide sign, you can say in a traumatized patient, there is no pneumothorax where I'm scanning the patient, because if there is a glide sign, it means that the pleural line is here, it's normal, it's completely, the two pleural lines are very close together, which means that there is no pneumothorax. So if you see a glide sign, or if you see a B lines, the B lines that we will see after that, they are pathologic, but they're coming from the pleural line. So if you see B lines, if you see glide signs, you can rule out a pneumothorax. So I don't know if you see it on this video, but it's very, very subtle sometimes, but you can definitely see some gliding signs on this hyperechoic pleural line. Next. So that was an example again to see a glide sign, and when you don't see a glide sign, to show you the suspicion of pneumothorax. So I don't know if each of this video is going to work. I'm very sorry, guys, if it doesn't work. It's not going to work, I think. I have more video after that, so we'll see. No? Okay, so we can move, but really, again, it's very important for you to train yourself, really to train yourself and to try to get used to see a glide sign, which is again a normal picture. So you can see on this picture, so it was the same Malamute of the previous slide with a traumatic event. So he was hit by a car and he developed a pneumothorax, as you can see on these x-rays. And we did a CT. So I don't know, we can maybe try to make the CT happening. I don't know if it's going to go, but there is a video normally. Yes, so this is the CT. I really don't know why this one is working, but it's working, which is good. So you can see the CT of the chest of this dog. So you can see the pneumothorax coming here. on the left side and the right, but more pronounced on the left sides. So why do we do a CT? Why should we do just a TFAS to diagnose a pneumothorax? Should we do just an X-rays? I mean, it's going to depend on the finances of your owner, but they did a study just to see how the TFAS was specific and sensitive compared to X-rays and compared to a scan for the traumatized patients. So what did they show is that there was a moderate to excellent agreement between AFAS and TFAS and CT for the detection of free peritoneal or thoracic fluid. So again, when you look at some effusion, if you do a TFAS or AFAS, you can be quite comfortable that if you see fluid, it means that there is fluid. If you don't see fluids, it means that there is no fluid. There was only a fair to moderate agreement between the TFAS and the CT for the detection of pleural fluid. So the pleural the chest cavity is a little bit more difficult to be sure. You can miss some amount of pleural fluid. It's a little bit not as good as the abdominal effusion, but it's still quite okay for the agreement. But they did see that there was a poor agreement between the TFAS and the CT for the detection of pneumothorax. This means that the CT remains the gold standard test and diagnostic to diagnose a pneumothorax. The TFAS, again, you can suspect if there is a pneumothorax or if there is no pneumothorax, but it means it asks for more experience, and the sensitivity and specificity is definitely not 100%. So when we focus a little bit more on the pneumothorax, because again, when we seeing a pleural effusion is quite easy. Seeing a pericardial effusion is quite easy. But when you have an unstable patient that has been hit by car or had a traumatic event and is breathing very, very badly, and you don't know if there is a pneumothorax or if there is a pneumothorax, you can try to do your TFAS, because again, your TFAS can bring you a lot of information. And for the pneumothorax research especially, you can look for the lung points. So what is a lung point? Is the transition zone of where there is a pneumothorax and the lung contacting again to the thoracic wall. So you can see, so it means basically the end of the pneumothorax. So you can see on this picture that there is a partial pneumothorax. So on the right side of the picture, you can see that there is a mild pneumothorax on the dorsal view, and the lungs after that looks okay. So if you look at the point where you see again the contact of the lungs with the thoracic wall, which is called the lung point, you can say, yes, my pneumothorax ends at this point. So on the next slide, so we're going to see that unfortunately, it can be more challenging than what we think in theory. So the A picture is a normal lung on the right and on the left. And if you put the probe on the dorsal view, which is where we look for the pneumothorax because the air goes dorsal, we should see a glide sign, a normal glide sign. Second picture in the middle, so you can see a pneumothorax, and it's a nice and gentle pneumothorax that has read the book because it's dorsal. So you can see that if you put your probe on the number 1 position, you should not see a glide sign because there is the pneumothorax. The probe number 3, there is normal lung because the pneumothorax is not here anymore, so you should see a glide sign. And on the number 2, this is where you should see your lung points, so the zone where the lung recontact with the thoracic wall, because this is the end of the pneumothorax. But as you can see on the right part of the picture, so the pneumothorax here on the number C is going a little bit funny because it's going vertically through all the lung of the lungs. So in this case, if you put your probe, the 1, 2, and 3 position, you should not see a glide sign, unfortunately, and you should not see a lung point. So many studies, if you are interested in TFAS and AFAS, but especially in TFAS, there is many dozen and dozen of articles that has been published recently for the last 10 years. So this one was one of the first one. So it was in 145 traumatized dog. So they wanted to use the TFAS to detect the pneumothorax. What they could see is that the sensitivity, specificity, and accuracy when they were comparing to the chest x-rays, were not too bad, but they were not perfect. And what the specialists saw is that the TFAS was a technique that did require some experience. So the sensitivity to detect a pneumothorax increased and reached the 95% for the vets that were used to do TFAS and that has performed at least more than 95 scans, compared to a sensitivity of 45 only for the vets that were pretty new with this technique. And as you can see, TFAS was being made in 3 minutes, so very, very quick. So again, for pneumothorax in a traumatized patient, the TFAS has a quite high negative predictive value. Why? Because if you see a glide sign visible, you can for sure rule out a pneumothorax. But if you don't see a glide sign, you can suspect a pneumothorax, but the sensitivity will be not perfect. The curtain signs, again, now, so it's a different picture, it's a different term, and it's a different information we can take from the TFAS. So what is the curtain sign? It's physiologic, it's normal, and this is the vertical demarcation that refers to the phenomenon of the lung sweeping down during the inspiration over the abdominal organs. So we can try maybe to make the video happen here, if it works. Yes. So this is between the junction between the thorax and the abdomen. And as you can see, so the liver is on the right, the lung is on the left, and you can see it's going back and forth as a curtain. So this dog, again, was the Malamute, and he was under GS. So he's breathing very, very slowly, but you can see the liver going right to the left as a curtain sign. So this is, again, normal. This is just when during the inspiration and expiration, the lungs move and go over the abdominal organs. So again, there is some more picture of curtain signs. So we can maybe try to see if it works. Yes. So again, back and forth. We can try, so you can see on the left the lungs, and on the right there is the liver, probably a part of stomach, and it is going back and forth. So this is normal. And there is another one. So again, so this is the contrary now. So because the probably was the pointer was going on the other direction, but on the left there is the liver and the stomach, and on the right there is the lungs, and you can see this movement, regular movement going back and forth. So quickly, because I'm not going to go in detail, because this is very, very new and it's very, very difficult to diagnose and to detect. But Boiron recently, with one of his very good friends, did detect a new abnormality, what they call the abnormal curtain signs, or double curtain signs, which is apparently a new diagnosis tool to detect a pneumothorax. So it's quite difficult to look. We can run the video if it works, but this is, so it's very subtle, but it's not a normal curtain signs, because it's coming from 2 points that going far and close together. I don't know if you can see, but again, it's very, very subtle. I'm not going to spend a lot of time here because it's very difficult to diagnose, but this is something new. So you may see more articles in the future about these abnormal curtain signs. So now, if we move on, because we said TFAS is a pericardial and abdominal effusion, and also for pneumothorax, but a few years later, we had a new protocol, which is called the VET Blue protocol for vet bed lung ultrasound evaluation. And this is just an expansion of the TFAS to assess not just the effusion, but to assess the proper lung parenchymal, and to assess if there is a presence or not of interstitial alveolar disease. So basically, it's to diagnose and to differentiate wet versus dry lung. So compared to the TFAS, there is a little bit more of a view to look. So you have the chest tube side view, or the cododorsal lung view, the perihilar lung region, the middle lung lobe region, and the cranial lung region. So basically, it's to see a little bit more of area of the lungs to assess the heart and to assess the lung. So as you can see, on the vet blue, this is where you're going to look for the B lines, because the B lines are a detection of a lung parenchymal disease. So the B lines, I don't know if you are comfortable to look at the B lines, but there are some big difference between the A lines and the B lines. So the B lines, they are definitely pathologic, or most of the time when there are more than 3 B lines per site, it's abnormal and it's pathological. And they are vertical compared to the A lines that are horizontal. So the B lines are vertical, they are perpendicular, they're going to arise from the pro lines, and they are going to be over the A lines. And so again, if there is more than 3 B lines in one site of scan, this is pathologic and represent a problem, a wet lung. So you have on this slide again the different points that you need to check, and you need to assess the number of B lines if they are present, to count 1, 2, 3, or more than 3. And more than 3, it's going to be a wet lung. So it's an example here. So you have the short white line, and that represent the pro lines. The pro line is also showed by the black one, the black arrow. You have the rib that are also represented, and you can see 1, 2, 3, 4 white perpendicular line coming from the pro line, and these are B lines. There are 4 B lines in this site, so this is pathological. This is another type of B line. So you can see very well the very hyperechoic pro line here. And it's very fuzzy. There are so many B lines coming that we call them coalescent B lines. So definitely a wet lung, and with a quite more pronounced and severe disease. And here, so we are in the middle. So you can see the diaphragm here, the liver on the top and the lungs below. And you can see a lot of B lines. You can almost count all of them. There are definitely more than 3, but it's less than the left one, but more than the right one. So we are in the middle, but definitely a wet lung also here. So again, B lines correspond to a wet lung. And why do we have a wet lung? It can be due to many things. It could be a cardiogenic pulmonary edema, could be a non-cardiogenic pulmonary edema. It can be pulmonary contusion, lung hemorrhage, or pneumonia. You can have more information depending on the history of the patient, but also via the distribution of the B lines. So very important to look where they are and how many they are. And again, if you see B lines, you on the side that you are scanning, you can rule out the pneumothorax. So again, a little bit more of images, if it works, I hope, but let's see. So this is a dog with a pneumonia. So they are not working, I think. Okay, we will have more after. So finger crossed, they're going to work. But it's just to show you. So you start. There is different technique to do a TFAST. Personally, I always, and I think it's better, I always start from the dorsal of the chest of the dog, and I go down just to check the full length of the lungs to see if, because you can see B lines, for example, in one side and no B lines on another side. So if you don't want to miss, you should screen the chest very, very closely. Next. Okay, so this is a dog. So the dog before was a dog with an aspiration pneumonia. So we couldn't see the video, but if we were able to see the video, we would have seen the B lines quite ventral in the lungs of this dog. This dog was a Cavalier King Charles, of course, so we know that they are very, very cardiac. So this dog was in pulmonary edema due to a cardiac insufficiency. So you can see on this picture on the right that being comfortable to do a TFAST can also give you a lot of information by screening dogs and cats coming in respiratory distress and seeing if it's due to a cardiac problem or if it's due to a no cardiac problem. And this is an amazing information that you can get from this TFAST. How can we do this? So you can be, if you are comfortable to assess your left atrium aorta ratio, you will have fundamental information, and you can say in 2 minutes, okay, this respiratory distress is likely due to a cardiac disease and pulmonary edema or not. So in this view, you can see that the aorta is tiny compared to the left atrium. The ratio here is 2.6, and when it's above 1.3 in dogs and 1.6 in cats, we can say that it's abnormal. So if the patient is in respiratory distress, you may suspect that it's due to a cardiac decompensation. So I don't know if we can try to maybe run the video of this dog. There is maybe a video here. Yeah, I don't know if it's going to work. Oh, it's not working. I'm very sad. Oh, I'm very sad. But this view of the LA-AO ratio is coming from this scan. So on this scan, what I was showing you is that, again, the best for you to be comfortable is to practice. But just to give you a tip to get an LA-AO ratio view is to go for sure cranial and ventral, and to have your pointer heading to in direction of the head of the patient to get your mushroom views. You need to have your mushroom view of the heart to start, and then you're going to do a counterclock rotation of 90 degrees counterclock to get this view of the LA-AO ratio. Most of the time, you need to go one intercostal space more cranial compared to your mushroom view to see this LA-AO ratio view. So 90 degrees counterclock rotation plus going forward by one intercostal space more cranial, and you should see this view. Again, it's the theory. Sometimes you need to move, you need to have another position, but this is most of the time the technique that is quite successful. So let's try this one, if it works. It doesn't work. It doesn't work. So this one says it was just to show you some B-lines because the dog was in pulmonary, had some pulmonary edema, so you could see a lot of B-lines on this one. Another one, a cat with dyspnea. So again, cats can come in respiratory distress, and sometimes it's very stressful for us to try to see what is the cause of the respiratory distress. So I don't know if it works, this one or not. Yes, and there is another one here also, if it works. Okay, so you can see this cat very, very unwell, very, very tachypnic. It's not doing very well. And you can see on the TFAS, so the TFAS, if we rerun it, so you can see that the ventricles are beating, but you can see that the atria, which are on the right bottom part, is very, very big and is not contracting. So this is also concerning for a cardiac disease, and there is also some trace of pericardial effusion in this cat. I don't know if you see the pericardial effusion, but this is, yeah. So this is definitely around the heart. So big atria that are not contracting, there is some pericardial effusion. So just with this and this respiratory distress cat, you can suspect that it's coming from a cardiac disease. Again, the TFAS will never replace an echocardiography from a specialist or not, but it can give you, again, a lot of information very, very quickly, and to initiate a therapy with furosemide, for example, in this cat. So cardiac versus respiratory dyspnea, again, cardiac, you will see B-lines, and you need to consider the distribution. You will see a big left atrium that can suggest a left-sided congestive heart failure, altered contractility in big dogs, for example, with DCM. You can definitely, if you are used to see a normal contracting heart, you can see the difference and a poor contractility, poor contractile heart, again, if you are comfortable with your technique. And also be able to see some hypertrophy in HCM cats. Respiratory, again, B-lines, yes. So as for the cardiac source, but again, consider the distribution. You can see pleural effusion in case of pyothorax, for example, or many other cases. And you can see a right-sided cardiac enlargement secondary to pulmonary hypertension. Again, if you are used and comfortable in the images. So another example, if the video works, we can try. Yes, so that was a puppy that was hit by car. So we very, very severely distressed puppy, and we do a TFAS. You can see coalescent B-lines. So here it's impossible to count the B-lines. They are too numerous. They are very fuzzy, very, very white. A picture on your screen. And so when you do the correlation, you can see the pleural line that is very, very hyperechoic, the B lines coming from the pleural line. So a young dog, we know that it had a trauma. You do a TFAS like this, you can highly suspect pulmonary contusion and pulmonary hemorrhage. So again, this can give you a lot of information. So there is other signs that you can see when you do a TFAST. So you can see a disruption in the normal line of the pleural line. So again, it can be a pleural effusion, it can be intercostal tears, it can be due to rib fracture, and it can be due to diaphragmatic hernia. You can see also a shred signs. So shred signs, what we call shred signs, it's a type of consolidation of the lung that can be due to a mass, can be due to pus, can be due to blood, can be due to water in the alveoli. So it's basically just a step after the B-lines of severity of the interstitial alveolar disease. So shred sign. So with the shred sign, you will see some air coming from the piece of lung that is consolidated. When we come to the tissue lines, so this is where the consolidation is much more severe, and there is a complete lack of aerated lung. So you should not see any air coming from this piece of lung that is consolidated, and it can be consolidated because of severe pneumonia or atelectasis, or also coming from a pulmonary mass. So let's see if this works. Yes, so this is an example. So you have the heart on the right, and you have this piece on the top that looks like almost a liver, like a liver tissue, a liver parenchymal. So if we run it again, you can see that it really has a tissue appearance, and you can see that there is no air coming. There is nothing. It looks like a piece of liver in the lung. So this is a severely consolidated lung globe. Again, doing the TFAS can't give you the diagnosis, but you need to take in consideration the rest of your patient's signalment and history to get more information. Nodule signs is the last one that you can detect. So again, it's going to be consolidated, but it's going to have this appearance of nodule, as you can see on this picture. So usually it's very focal, very well marginated or circular, and you can see air coming from the bottom of this nodule. And when you see that, it's like in X-rays, you can suspect a METS, you can suspect a granuloma. Very, very important when you see that to go further in the investigation if it's possible. If it's not possible and you have a good imager, you can ask him to poke the nodule after you see this. Last slides for the TFAS part, or at least for the thoracic POCUS. So as I said, if you are comfortable with the different normal view and also the most frequent abnormal view of the TFAS, you can see many things, very interesting things, just by doing your POCUS and looking at the heart. So on the left side, we can see that this ventricle looks very thickened, almost like a HCM cat heart. So it can come from a cat, but it also can come from a dog. And when you see that, again, by linking the history, you can highly suspect hypovolemia, and we call it a pseudo-hypertrophy heart. In the middle, you can see that the right side of the heart is very distended, and the interventricular septum is super flat. So this is typical for pulmonary hypertension. So if you're able to see that, and if you have a cat or a dog coming in respiratory distress, you can highly suspect that this patient is suffering from pulmonary hypertension. There is a lot of differentials to explain pulmonary hypertension, but at least you did suspect the right things. And on the right side, so this is a very distended left ventricle, likely also the right ventricle, and you can also suspect on this one likely a dilated cardiomyopathy, and usually it's also accompanied by a decrease in contractility that you can see and assess also by doing your POCUS. Few articles to finish, because it's always good to see what we do in research and what we get from this. So it's just few articles that show you the importance of doing a TFAS in respiratory distress patients. So the one on the left did assess the TFAS in normal dogs and dogs with cardiogenic pulmonary edema. So it was a pilot study, and what did they show? They showed that that doing the TFAS, it supports that the use of the TFAS and the detection of B-line was a good technique to diagnose cardiogenic pulmonary edema in dogs. And the more severe the pulmonary edema was, and the most important number of B-lines they were going to see. And again, the same for the cats and the dogs to diagnose cardiogenic pulmonary edema. So it was in acute dyspnea, another study that confirmed that the use of the TFAS by doing this compared to the X-rays is definitely not bad. And remember that when you have a dog in respiratory distress, it's sometimes impossible to do X-rays, or you take the risk for your patient to crash and die. Another study to assess TFAS and B-lines in dogs with different stages of chronic valvular heart disease. So basically what to retain is that it's still a good diagnostic tool to identify the pulmonary edema, but also that the more severe it is and the most significant TFAS abnormality you will see. So next. So now we can move on the abdominal part of the POCUS. So it's going to be it's more simple in general, but it's also still very important to know what we are looking for. So indication to detect small amount of peritoneal effusion. It can predict the degree of anemia in dog with traumatic or non-traumatic hemorrhage by doing and assessing an abdominal fluid score. So we know that when you have, for example, a traumatized patient, if you see effusion in 1 or 2 quadrants, it's going to be the small bleeders, and the 3 or 4 positive quadrants is going to be a big bleeders. It makes sense. It's not very revolutionary, but yeah. So this is what they showed. You can diagnose and monitor for peritonitis. You can detect retroperitoneal effusion. You can also screen for anaphylaxis. So this is more and more fashion for the last few years. So to diagnose, and I don't know if you did diagnose already in your practice, but hemoperitoneum due to anaphylaxis in dogs. And so this is not uncommon to see dogs that were completely fine, and they are presenting because they are suddenly very sick, very lethargic, and you do your TFAS, FAS, and on your FAS you see an hemo abdomen. And usually, I mean, if it's a young dog, it's hard to believe that it's going to be an hemangiosarcoma or something like this. And if you listen to the history of the owner, they say that the dog was completely normal before. And if you see even a gallbladder double rim or halo signs around the gallbladder, you can definitely suspect an anaphylaxis reaction. And there is a very recent article that I put in this slide. I really recommend you to read it if you are interested, because again, it can help you in some desperate moment when you see a young dog that was completely fine before and it's coming, you do an FAS and it has an hemo abdomen, to not condemn this dog and to maybe think about an anaphylactic reaction. And by doing the abdominal ultrasound, the FAS, you can also assess the volume status and the right-sided cardiac function by assessing the caudal vena cava and to evaluate for the presence of hepatic venous distension. Limitation. So if you see fluid, you can't characterize the fluid. So you will always need to take a sample. Again, FAS or TFAS, it can't give you a final diagnosis, and it can't prevent you to do more tests when it's needed. There is a risk of missing effusion, yes, if a patient is dehydrated or hypotensive. And in cats, it cannot be used to predict anemia. So, very simple technique for the FAS. So you check 4 quadrants to detect the presence of fluid in the abdominal cavity. So the splenico-renal on the left, the hepatorenal on the right, and the systolic on the caudal part. And you should try to move your probe in a line of 4 centimeters about. It's just the theory, but you can be more wider in the practice. And you can also assess the abdominal fluid score, especially for the traumatized patient or the post-op patient, for example. So again, if you see effusion, you're going to have to go forward because you're going to need to know what is the effusion. But you have 3 examples here. So you have the urinary bladder on the left one, and you have free fluid below the urinary bladder. You have the spleen in the middle and the kidney, and you have some free fluid between the spleen and the kidney. And you have some free fluid I think it's caudal to it's between the spleen and the liver on the right side. So depending on where is the fluid, depending on the history of your patient, if you see fluid, you need absolutely, and I highly recommend to poke every time you can poke a fluid to get a sample. And if you see an hemorrhagic fluid, it can be an hemoabdomen. If your hematocrit is at least more than 25% of the hematocrit of your blood. It's going to be urine if your creatinine in your effusion is at least double compared to the creatinine in the blood, and if your potassium in the fluid is higher by 1.4 in the dog and 1.7 in the cats. Bile, it can be a biliary peritonitis, so you can just check the bilirubin in your effusion, and if it's at least double compared to the bilirubin in your blood, you can have a diagnosis of biliary effusion. Biliary peritonitis. And septic, we all know how to do a septic peritonitis diagnosis by comparing the lactate and the glucose. So we can go quite fast for this because I'm sure you know the technique, but you place the probe for the diaphragmatico-hepatico view, immediately caudal to the xiphoid process. And in this view, you can see the gallbladder. If you go deep enough, you can fan up and down your probe, and you can see so that you can see some small volume of fluid that can be between the different liver lobes and between the diaphragm. You sometimes, depending on the morphology of your patient, you need to push and to go quite cranial to see what you want to see. So example, you can see the liver, the diaphragm, and you need to be careful because for each test, you can misdiagnose some few things. You can have some false positives. So here, for example, on the left, you can see the gallbladder, but if you are not used, or if you go quickly, or if we do a screen, if we freeze the picture, you can maybe suspect that there is free fluid, but no, it's just the gallbladder. And on the right side, again, you can see some anechoic part in this picture, and you can see, oh, maybe there is some free fluid in between two liver lobes, but no, it's just the vessels that you can see, the hepatic vessels that are a little bit dilated. So it's not free fluid, it's just vascularization. The splenorenal view, the position of the probe is longitudinally, more or less parallel to the spine, just caudal to the costal arch. So in this view, you will be able to visualize both the spleen and the left kidney. So again, you're going to fan cranially under the rib towards the table top if the patient is in lateral recumbency. And you can take your time to look at the spleen, look at the kidney, see if there is any effusion around the kidney into the retroperitoneal space or not. And sometimes you can also see the aorta and the caudal vena cava. Cystochoric view, probably the most easiest one to do, is mainly to look at the urinary bladder. So you can put your probe in the caudal part of the abdomen, and you will see, hopefully, a bladder. Should be anechoic fluid into the bladder. And if there is fluid around the bladder, this is not normal, and maybe you can suspect some degree of uroabdomen, for example, if it's a traumatized patient, or an hemoabdomen. But again, each patient is different, and it will depend of the history of your patient. And the last one, the hepatorenal view. So you're going to place the probe just ventral to the umbilicus. So direct the probe downwards towards the table top to the most gravity dependent site. So it can be difficult to see the liver unless the liver is big, but what you're going to see the right kidney. That can be, usually the right kidney is more difficult to see compared to the left kidney because the right kidney is more cranially located in the abdomen. So sometimes you need to push a lot and the patient doesn't like it, but sometimes you need to do this. And you will see also some small intestinal loops and walls. So if you have effusion, they will be floating into the effusion. So you can get a lot of information again from this hepatorenal view. False positive, be careful. You can see if you have intestine with a lot of fluid in it, if you have some ileus, you will have some dilated intestinal loops that will have anechoic fluid. So be careful to not think it's effusion because it can be just a very distended intestine. You can also see fluid-filled uterus, so the same principle to not misdiagnose and confound a fluid-filled uterus and a fluid-filled intestine. Let's see if this works. It doesn't work, but not very interesting. It's just abdominal effusion, and I'm sure you did see, and you are seeing, or maybe not every day, but very often dogs presenting to you with abdominal effusion, and doing an fast. Again, it's quite easy and quick to be able to see abdominal effusion. So if you want to go a little bit more deep in the technique of the FFAST, so as I said, FFAST initially is just due to detect abdominal effusion, but you can go a little bit further, and depending on what your patient present as abnormalities in his physical exam or in his bloods, you can look for some difference between the echogenicity of the liver lobe, and you can see maybe a mass in the liver, for example, or if you can see maybe a gallbladder that is full, if there is maybe a beginning of a start of mucocele. This is all information that you can grab from your FFAST. But again, and this is what I say every day to my intern or assistant, is that I mean, as an ECC clinician, we are not imaging specialists. So, and sometimes it's very, very quick and very, very easy to overdiagnose something that we want to diagnose. So yes, it can give you information, but don't forget to ask for full ultrasound when you see something abnormal. If we focus on the kidney exam, again, if you have a dog or a cat that has an abnormal urine analysis, his POPD, has an AKI, has discrepancy in the renal size on your physical exam and abdominal palpation, or if it's painful, you can look at the kidney more closely with your hepatorenal or splenicorenal view, and you may be able to detect pylectasia or kidney stones, or if your cortex of the kidney is super hyperechoic. These are all information abnormalities that you can see and you can detect, and it can help you in the direction to go for your therapy and diagnosis. Spleen, the focus on the spleen. So again, if you have an organomegaly on cranial, if you have abdominal pain, if there is a trauma, if there is some hematological disorder, if there is an anemia or thrombocytopenia, we know that physiologically the spleen is going to react, it's going to do something. And when you focus more on the splenic exam on your FFAST, you can see masses, you can see if the spleen is very big, if there is a splenomegaly or not, if there is a mottled spleen in case of neoplasia. So again, main information that you can get from a quick FFAST. Bladder, again, it's probably the simplest one, but if you have a patient with some urinary signs or history of calculi or caudal abdominal pain, it's quite easy to see, first of all, if there is a bladder or not, if there is a stone in the bladder. So if you see some shallowing dark cone in the bladder, it can be suspicious for stones. You can see also if there is a lot of snow in your bladder, it may be a lot of crystals or a lot of sediment in your bladder. So again, I can't list the number of abnormality and information that an FFAST as a TFAST can give you. So if you are curious, if you are interested in scan, really just train yourself to scan everything you can scan to get as many information as you can. And last one, GI and pancreas, as I said, so you can see if there is some distension of the loops, intestinal loops. If you are used to see normal intestinal loops during your FFAST, you may be able to see something abnormal, or if there is a mass, or if there is anything abnormal. It's more difficult, definitely, to look at the GI during an FFAST because it's definitely not the goal for this, but during a view, hepatorenal or splenicorenal, for example, you may see something abnormal that may request some more investigation after that. To finish, interesting article. So it's a quite old that article. It was published in 2009. So it was one of the first one studying the TFAST and EFAST. So this one was for the EFAST. So it was the evaluation of the abdominal fluid scoring system. So the AFS, determined by using the EFAST for traumatized patients. So there was 101 dogs that were hit by car, and they did detect abdominal fluid in 27% of the case. And in 52% of this case, they had the abdominal score 3 to 4. So they were the big bleeder. And in this patient, they had a lower hematocrit, they had lower platelets count, and they had an increased ALT, which were all in favor of a more severe trauma. And this, when they had an abdominal fluid score of 3 to 4, they had an increased risk of transfusion needs. So important to detect, for each traumatized patient to do a full TFAST and a full EFAST. And if your EFAST is positive or negative, it's going to be very important to track it, to repeat it in the next few 24 or 48 hours, just to be sure that your patient is not getting worse and is not deteriorating. A little bit more, because I think now that you know that I love TFAST and EFAST. So for the EFAST, just examples of more articles to show you what you can learn from EFAST. So there is, for example, the first one was quite recent, and they just determined a new formulation to calculate and to evaluate the bladder size and the amount of urine volume that you can assess by measuring your bladder during your EFAST. So this is the quite complicated formulation that they did determine. And they also did study in non-traumatized patients, because they also did show that doing EFAST in non-traumatized emergency patients was very helpful to detect specific pathology. Even if they were not, they didn't have trauma, they can have a free fluid, and you can detect it during your EFAST. And also for the urethral obstruction cats, so there was many studies assessing the needs or the utility to do cystosynthesis for them. So this is also a use of EFAST, and especially for the caudal view to help you to do your cystosynthesis.